Hello, this is Jerome Fryer, Chiropractor. I wanted to put together a video to explain a few things regarding what we do as chiropractors and what we look for and how we go about helping people. So some of you may know that I am a model maker as well, and I found that there was significant lack of modeling in spine, and I began developing these spine models so we can talk a little bit more intelligently about where and what we're doing as doctors. So I first wanted to show you, this is our most popular model here, and it's an L4-5, which is in the lumbar lower back. This is the back part of your spine here. You can feel these bumps as you run your hand down the back of your spine, and this is the front. So your abdomen is more out in this region, so it sits quite back into the body. So let me show you a more full model, or at least a couple different levels here. Now this is a model that I developed as well. You can see it has the sacrum. Some people call this the tailbone, but the tailbone is right here, called the coccyx. And this is the sacrum, and we can see L5, L4, and L3. And one of the things that we look for is, of course, where the pain is coming from, because that's often what brings people into the clinic. And one of the things that we do as chiropractors is to evaluate range of motion. So what I do is, first of all, observe patients coming in, and often you'll see patients kind of leaned over to the side like this. This is called antalgia, and often patients think that something is out of alignment per se when the body is kind of leaned over in this type of a fashion. But if you look carefully, what happens when you lean over, it creates sort of space in certain regions that are often causing a patient the problem. So you can see here, this joint right here, when someone leans over, for example, what it does is it creates more space in that joint. So instead of it being out of alignment, it's a way to avoid the pain. The body has a way of moving over to avoid the pain pattern. So some people have this antalgia and some people don't. So that's often the first thing I'm looking for when patients kind of walk into the clinic is, whether they have a bit of a lean, or whether they're flexed forward, or they're bent a certain way, because it gives us clues on where the pain is coming from. So most often, and not only me, but range of motion is a standard when it comes to an examination. So when a patient bends forward, for example, bends forward this way, you can see that there is compression on this structure here, which is the intervertebral disc, and also a stretching of those joints forward like this. So if someone has pain bending forward, it depends on whereabouts it hurts. Does it hurt right in the very beginning? Does it hurt when they're down a little further? It gives us clues on where the problems are coming from. And most often the pain is originating from this structure right here, the intervertebral disc. And I'll get to that in a little bit here. So for example, if someone has pain when they bend forward, and they say, oh yeah, it hurts, they can present pain in this region very often here. Sometimes the pain presents anteriorly or to the front, and if patients have pain when they go into extension or bend backwards, for example, you can see that these joints slide together here, and if they say, oh yeah, it's hurt, it hurts when I go into extension or when I bend backwards, it gives us some clues that it's very likely this joint here. So once I've identified where the problem is, there is treatment to be performed. But first I want to show you sort of a cross-section of this structure in here and also in this region here. Okay, and this is a relatively healthy lumbar spine, or probably a 35, 40-year-old with not much wear and tear. And I'll show you an older spine here as we move on in this video here. So first of all, let's look at a cross section of this area right in here. So if you look here, right, I've colored these bones so we can see the structures a little bit more clearly. This disc here, when we look down into the disc, what we do see, you can see here at about 11 o'clock there's this tear, okay? So the disc is made up of two different materials, a nucleus in the middle, which is clear here so you can see down through. The blue that you see there is the top of this vertebrae here, right at the top here, okay? And that's where the nutrition and the hydraulics work through. That's where those black specks are in the distance there. It's maybe hard to see a little bit, but they're there. But I want to kind of cast your eye onto this white part, which is an annulus, which encircles this nucleus to contain it in the middle. And what happens is these little cracks that develop, okay? And when these cracks develop in here, what happens is if it cracks too far, you probably have heard of a disc herniation, but you can get a crack that goes all the way through. And if someone bends forward, for example, you can see how the nucleus will actually push up against that nerve. You see that? That creates often pain locally and then down the leg or into the buttocks. And if you look at, see, that's one cause of pain, and that's usually pretty intense, is when that nucleus abuts that nerve root. But another cause of pain is if you look on the outer aspect of this white part, and let's take another cross section, there's particular nerves that are of interest, and this is called the sinovertebral nerve. So you can see here what I've done is I've cross-sectioned this vertebrae, and you can see on the outer aspect of this vertebrae there's nerves. This is called the sinovertebral nerve, or disc innervation. And you can see that there are nerves only on the outer third of this annulus, okay, on the outer third of this white part. And so if you get a little crack on the inside, your body doesn't even identify it as pain. But what happens is if you do get a crack, this is what's interesting about the human body, particularly the lower back, is that when the crack develops, what happens is the nerves begin to, just doing this outside here, a little bit more pleasant, until that happens. Anyways, when a crack develops, what happens is the nerves start to grow in to the inner two-thirds, and you can see that, right? The nucleus is kind of a soft jelly material like this, and what happens is now what was originally non-innervated now becomes innervated. And there are theories regarding why the nerves grow into the tissue, but naturally it's to protect the body, to prevent and let the organism or the person know not to create any more unwanted stress into that annulus, and we don't want it to push all the way through and push up against the nerve root, for example, right? So let's get back to this one here. So that's a very common cause of pain, is right in the disc itself. When something happens, a little crack develops, and there are nerves on the outer outer third, and then when the nerves, when there's a crack on the inner two-thirds, nerves grow into that and make it more pain sensitive. So another common pain generator is this facet joint, as I was showing before in that more full spine model. You can see here the red is the blood vessels underneath the blue, which is cartilage. So what happens is, very often, disc will lose height over time. So the disc will lose height, and you can see how this joint here, which blue is the cartilage, which is about 0.5 millimeters thick, it will rub and cause, it's called imbrication, or where the joint kind of rubs together, and then underneath that blue is red, which is where the pain sensitive nerves are. So if this is painful, often patients will be in a state of a little bit of flexion, okay, bent forward, just to create a little bit more spacing. Or if they roll over in bed, for example, you can see that these joints will rub up and kind of push into one another. Okay, so those are two very common pain generators: the facet joint and then the disc, and then of course the nerve root that gets pinched. Now in an older spine, what we have is, I think this is called a stenosis model that I build, but you can see that the facet joint is arthritic, right, compared to what you just saw. Or you see how that's nice and smooth and good spacing? Well, what happens is, once the disc loses its height, then the facet starts to rub together, and this arthritic process begins. Okay? Now, this limits motion, decreases flexibility, of course, and importantly, you can see how this is called the IVF here. This sort of ovoid sort of hole there, that's where the nerve exits, right? And this is quite open. You can see how much more room there is with this one here. The other problem is, if the nerve comes out and gets pinched in this area, another problem is in this region here, which is the spinal canal. You can see here that the spinal canal is actually narrowed from the back and from the front with the disc, and from the back the ligament flavum. So when this gets below 10 millimeters, then that's when we start thinking about it being stenotic. So I want to show you a couple more here. This is a recent model that I created. It's a mid-sagittal, which means it's kind of split, right? Split right down the middle. Often we see this on MRI, these images like this, and you can see here the nucleus in the middle most aspect, and then you've got the annulus, and you can see there's a little tear that I created here, and under flexion load you can see this is a herniation, right? So as the nucleus gets pushed through the outermost aspect of that annulus, that's a breach there. This is called a disc herniation. Okay, this is called the cancellous bone. Okay, and the cancellous bone, this is marrow. Okay, this is where the blood is made here, and it's just a neat model. There's some neat new research now that shows there are nerves that come through the back of the vertebrae right here and go down and innervate the top of the nucleus and the bottom of the nucleus to identify if that nucleus is pushing up too hard up against these vertebrae here. So you can see here, I've showcased it with this model here. This is called the basal vertebral nerve, and there's some new techniques out there now that actually ablate these nerves, and you know, in the spirit of trying to reduce back pain. Okay, so once we identified whether it's the disc or whether it's the facet joint that's the pain generator or something else, but most often it's either, you know, the disc or the facet joint. Then what we do is we render treatment. So one of the things that I do in the clinic to try and assess where the problem is I'll have patients lying on their stomach, and I'll push on certain structures, in particular the spinous processes, in different angles to try and determine which facet. So you can push this way, or you can push straight down, or you can have a little bit more of an angle this way or this way. And you can see that when you push straight down here, it's going to push those vertebrae together a little bit more. These facets, sorry, that facet against this facet will, I got some paint on my finger here from doing some of the models, but you can push here, and you can see if this space opens. Actually, the joint above will open, but if you push at this type of an angle and push down and push over here, you can get this to approximate. So that often helps me, because I ask patients, I go, okay, well, does it hurt when I push over this way, or if I push this way? Or, for example, if I push at particular landmarks like the sacrum here, and I push down and it creates more space, I say, is that relieving? And some patients say, oh yeah, no, that feels good, that feels good. So it gives me some clues on what structures to work on. So once I identify where the problem is, then I'll often render a little bit of decompression or flexion distraction, where I will do this type of a procedure, holding on to each vertebrae, or the selected vertebrae according to where the location is, and I'll stretch it this way. Right? This opens up the facet joint and also opens up the disc space. I will often have patients lying on their back, and I will render extension distraction. So I'll do it this way, right? Creating a low pressure within the disc space, always in an attempt to increase the disc height. And then sometimes manipulation is performed as well if the facets need gapping, for example. So what I'll do is I'll put them on their side, and what I'll do is I'll create a little bit of a short thrust like this. Okay, and what that does is sometimes a pop occurs in that region there when there's a nice clean separation of the joint. Sometimes it's not always performed, and sometimes it doesn't crack, sometimes because of the muscle spasms, or the muscles are kind of contracting it. Sometimes and patients will guard a little bit too, or sometimes when you have a, like for example, this type of a facet joint, it's hard pressed to get this thing to gap open cleanly, because there just isn't that range of motion at that level, right? So, you know, sometimes patients say, well, how come, you know, it pops and sometimes it doesn't, or I used to pop but now I don't pop anymore? Very likely because there's an arthritic process, or something else, like I explained there. Okay, so I hope you learned a few things, and if you have any questions, you can contact me directly through my website, drfryer.ca, and I hope this was informative. Thank you.